All right, everybody, we're back. We have Dr. Orren for this presentation on allergic reactions and anaphylaxis. Oh, you, Dr. Orren.
Okay. I'll say I'm usually not the loudest person, so if you can't hear me, just let me know. I'll try and speak up a little bit. So like it says, allergic reactions, anaphylaxis, and I also kind of talk a little bit about just other types of angioedema with ACE inhibitor induced and hereditary angioedema as well towards the end there. So just kind of a overall review, kind of allergic reactions and anaphylaxis are a subtype of hypersensitivity disorders. They fall into the type 1 type of hypersensitivity that are IgE mediated. So these occur within seconds to minutes of an exposure to an allergen. Then you have type 2, which is antibody mediated, type 3 immune complex. And then type 4 is your delayed type, which you can also see rashes as well. So those are going to be your kind of poison ivy, poison sumac, even latex or TB tests. Those are your type 4 mediated. So that's kind of one of the things I wanted to talk about, just the difference a little bit as well. So your type 1 hypersensitivity disorders, often people have a previous exposure. They oftentimes will have a known allergen that they're allergic to, but you can have up to 25% that have an allergic reaction or anaphylactic reaction that have never had any exposure to any allergen before, so they don't know that they have an allergy to it. Like I said, it occurs within seconds to minutes. Your most common allergens are foods, insect venom, your bee stings, wasps, and medications, your penicillin allergies, other sulfa, other types of drugs. And then anaphylaxis is essentially a special type of type 1 hypersensitivity reaction. And then your type 4 hypersensitivity reactions, like I said, those are your cell mediated. These can take hours to days to develop, but I think it is just something to kind of important to talk about just because they often present with a rash. Usually it's a localized rash for some sort of contact dermatitis type of thing. And these you'll see more often with blistering and vesicles versus your type 1 hypersensitivities with anaphylaxis, where it's more of an urticarial, blanchable rash. So I think if you come across somebody that you think they might be having an allergic reaction, just kind of being able to check out the rash to determine it could be more of a delayed type. So if you're seeing vesicles, especially that are in a string or like a train track kind of look, or there's blistering, it's less likely to be anaphylaxis and more of a type 4, which is like your poison ivy type of thing. Now, sometimes you can get the type 4s that can become severe as people tend to get exposure to poison ivy or something like that, and they're scratching and rubbing areas and they don't have any sort of rash or symptoms for days, so they're spreading it all over their body without knowing. And I've even seen some patients that end up with this type of swelling and vesicles and blisterings in their mouth due to just a severe allergic reaction to poison ivy. So that's something to kind of keep an eye on, but just being able to determine the difference between the rashes can clue you into whether it's a anaphylactic versus a type 4 hypersensitivity. And these patients can just be treated with Benadryl, topical steroid cream. They don't require generally anything additional to that. Sometimes if it's severe, they require some oral steroids, or you can do like IM Decadron or something like that as well.
You're fine, Doc. Just moving things around a little tad.
So kind of going towards your anaphylaxis. So there's essentially a 1 to 3% chance that somebody will have an anaphylactic reaction throughout their lifetime. And it's a systemic reaction to some sort of allergen. And the allergens can be anything that would otherwise be innocuous, but for whatever reason, the body has a reaction to it, which causes an immediate reaction via IgE and release of histamine and other chemicals throughout the body, and causes a systemic inflammatory response. So, again, the most common things are usually insect venom foods, medications. So anaphylaxis is just kind of, like I said, immune response to allergens. It's Ig mediated, and the biggest thing that is why it occurs within seconds is that you have all of these mast cells and other cells throughout the body that carry histamine in them, and IgE activates these cells, and there's an immediate release of histamine, which causes the immediate vasodilation, which leads to your rashes. And you can get your edema, tachycardia, and then histamine also causes a cascade of other chemokines, which are your prostaglandins and leukotrienes, which is why with anaphylaxis there is a chance of having a rebound effect even after being given epi, because you're essentially kind of blocking the effect of the histamine initially within those seconds to minutes, but the prostaglandins and leukotrienes, those don't have any effect. They're similar to steroids. It's like those don't have any effect for hours later. So you can have a rebound effect up to 8 to 11 hours after their initial treatment. And that's why when in the ER, we do watch them anytime anybody's given epi-IM. We watch them for a minimum of 4 hours, just to ensure that they don't have any other life-threatening events after their initial treatment. So kind of your classic symptoms you look for that a lot of people have is the flushing of the skin, the urticaria rash that is itchy. They have a foreign body or a fullness sensation in their throat. They have subjective kind of difficulty in swallowing. They'll be anxious, short of breath, chest tightness, lightheaded. Not necessarily dizzy, but just more of a lightheaded feeling. And anytime that there's a concern that somebody has a foreign body feeling in their throat, you should be on high alert to a possibility of laryngeal edema and the risk of loss of their airway at that point. So other signs that you can kind of look for outside of your subjective ones. Angioedema, whether it's the tongue, lips, you can even have them just isolated to the uvula as well. Any wheezing or stridor, tachycardia, hypoxia, those are some of the other signs to look for. And one of the things that oftentimes kind of goes by the wayside that people don't put together is that if you have somebody that has wheezing and a rash and they're having like nausea or any vomiting, the GI symptoms tend to get disregarded for people that have allergic reactions. And that's actually one of the most common symptoms. Almost 30% of patients have nausea or vomiting or diarrhea as one of their primary symptoms for anaphylaxis. So, the most common is the fullness in the throat, shortness of breath, angioedema, the urticaria or flushing, and then the GI symptoms. And for all of this, on the next slide, we kind of talk about the actual diagnosis and the criteria for it. But overall, the kind of rule of thumb is if there's two systems or more that they're having and with a known allergen, or if it's suspected, if they're having two systems that are affected or more, you should go ahead and give epi. As anaphylaxis is surprisingly underdiagnosed and people are rather resistant to giving epi for these patients. And the risk of death is highest within the first hour, and a lot of times it kind of gets missed because they have atypical symptoms. So if there's any time that they have more than one system that's being affected, it should be something that, as a differential, should be considered.
Dr. Warren, I have a question. They can't hear me, but just so you say not given in time. Is there a point in time where you can't give enough epi to get it back?
So there isn't a specific cutoff time as to when it's given. It's just at the point that a lot of times they'll start having these more non-specific symptoms, and it progresses to the point that they get the laryngeal edema to where trying to get an airway at that point is very difficult. And even, I mean, in the ER, so many providers are hesitant about doing crikes or anything like that. They wait and wait to try and get another type of airway that oftentimes by the time it gets to the point of criking a patient, they're already gone most of the time, just because a lot of providers are not comfortable with doing it. So they wait until it's like the critical point, and then they struggle with getting it, and by that time, a lot of times, they can't get them back. So it's better off if there's a suspicion giving it early, because your downside of giving epi, the risk is a lot lower than not giving it at all. So giving it early, like I said, within the first hour is when you have most of your deaths due to an anaphylaxis, especially ones that are medication induced, because they could take the medication for several days, and then it builds up in their system, and then all of a sudden they have a reaction. And it's not necessarily something that you can, prevent the exposure or anything. They've been taking this medication for 3 or 4 days, and then all of a sudden it becomes an allergen, and they can have a reaction right then and there. But it's built up in their system that within 20 minutes or so, they could have loss of airway at that point. So there isn't really a cutoff time as to when you can give the epi, but more often than not, we get to the point that it's unrecognized to where they end up having airway compromise, and then trying to go back and get that is difficult. So they end up with having to do a crike or a trach, and a lot of times those patients end up crashing before they can get those airways. So this is the criteria that we go off of for making the diagnosis of anaphylaxis. So if you have any of the classic symptoms plus respiratory compromise or hypotension, then it's considered to be an anaphylactic reaction. One of the biggest pitfalls that we kind of come across, and we'll talk about a little bit later, is you don't have to be hypotensive to diagnose anaphylaxis. And that's one of the things that, through the research I was looking at, is that most providers are waiting until they're starting to be shocky and hypotensive before they're willing to give epi. And that's one of the biggest downsides, is that they're waiting to the point that they're getting about to crump because they're becoming hypotensive before they give epi. So anytime you have these multiple systems that are affected, you should just go ahead and give it. So if you have any involvement in the skin, your rash, your flushing, you have edema of the mucosal tissue, whether it's buccal, your tongue, or the lips, pruritus, or just a lot of itching everywhere, even without a rash. They can just be itching all over the place. And then any sort of wheezing, dyspnea, or stridor. That would be enough to diagnose as anaphylaxis, and at that point you should go ahead and give them epi, or if they have hypotension as well. Now, the other part is if you have 2 or more of the following symptoms, it's likely that they're having an allergic reaction. So anytime you have those classic symptoms involving the skin or angioedema plus any of the GI symptoms, then it should be part of your differential. I actually had a patient about 3 weeks ago that had been receiving cefepime for their antibiotics, and she had been having this rash and flushing on her neck, and she was having nausea and vomiting every time she would get a dose of this medication. She was getting every 12 hours. So every time she got the dose, she would have this flushing of her skin, she would have nausea and vomiting, and no one ever put it together until I went down and saw her, and she had flushing that went all the way from her breast up her face, and it was itching, and then she was having nausea and vomiting. So that's technically enough to consider it an anaphylactic reaction to the medication. So we discontinued the medication, gave her Benadryl and steroids, and she cleared right up. And so we just made it an allergy for her in the future. So that technically is enough. She wasn't bad enough, really, that we had to give her the epi at that point. She was otherwise stable. But doing the Benadryl and just discontinuing the antibiotics was enough for her. Now, the other thing, too, is if somebody has any sort of allergic reaction to, like, the venom from a bee sting or something like that, removing the stinger is important. If it's known, if you can find it, or if they have some sort of reaction to a detergent on their clothes or anything like that, removing them from that exposure is important, because otherwise, no matter what your intervention is, if they had that continued exposure, it's still going to keep reoccurring. And anytime you have somebody that is hypotensive with a known history of anaphylaxis and a possible exposure to that known allergen, you should go ahead and treat them as if they are having an anaphylactic reaction and giving them epi. And just because they have stable vital signs, that does not mean that they're not having an anaphylactic reaction. It could just be early. And you should go ahead and still give it. So like I said, the downside, you might make them a little tachycardic, maybe having a little bit of GI upset or a headache, but overall your side effects of giving epi are fairly low. Now there are a couple special circumstances to watch out for, and I'll talk about those a little bit later. So your first line treatment for anaphylaxis is always going to be epi. Now if you're giving it IM, doing the 0.3 milligrams of the 1 to 1,000 for adults, and then it's 0.01 milligrams per kilogram of the 1 to 1,000 for pediatrics. And you can give it IV, but generally they try to reserve IV epi if it's refractory to multiple doses of IM epi, and you can give the IM epi every 5 to 10 minutes as needed if they're still having symptoms, or especially if they're still hypotensive after the initial dose. You can give it multiple more times, but if usually after 3 doses of IM if they remain hypotensive, then it recommends going ahead and giving them IV, and giving IV is 0.1 milligrams of the 1 to 1,000 in a 10 cc syringe of saline. So it's even further diluted down to 1 to 10,000 at that point. If they're hypoxic, giving the supplemental oxygen, as long as you're trying to maintain over 90%. Also giving them any sort of bronchodilators. The epi is a bronchodilator, but any sort of albuterol or Duonebs can be helpful for these patients as well. And giving Benadryl, you can do the Benadryl 50. You can do PO or IM or IV. All of them are pretty much equally effective at that point. And then Pepsid. Do y'all carry Pepsid on? Okay. And so Pepsid's one of the other drugs that we'll give them, usually in the ER for that. And then steroids, whether it's Solumedrol, Decadron, or Prednisone, they're all equally effective. The only downside is that if you're doing Solumedrol, you oftentimes will have to give them a steroid dose pack to go home with, versus giving Decadron just because the half-life lasts much longer. You can do that one time and they're good for a week. So this is kind of one of the special cases to watch out for. So if somebody's taking a beta blocker and they're potentially having an allergic reaction, a lot of times they can be resistant to getting the epi, and they can remain hypotensive. So you can give them a milligram of glucagon as you treat them as a beta blocker overdose to try and reverse that. And you can give that every 5 to 10 minutes as well, along with the epi if they're having refractory hypotension after initial dose if they're on beta blockers. The big kind of downside is giving somebody epi if it's just suspected that they're having an anaphylactic reaction if they're on beta blockers, is you could have that severe rebound hypertension where you had the unabated alpha stimulation, but that is more of a theoretical. It doesn't happen that often. And so I think it was less than 2% of cases that somebody who had a beta blocker and received epi and had severe hypertension. So your risk overall to the patient is still fairly low, and giving epi early is better. And then the second line treatments, we talked about the Benadryl, steroids, and if somebody has a history of COPD or asthma, or if they just have any sort of wheezing at all, giving them albuterol or doing that breathing treatments can be beneficial for them, as well as if they're still kind of refractory wheezing after receiving a Duaneb or albuterol breathing treatment, then you can give them 2 milligrams of magnesium as well, and it'd be a bronchodilator and smooth muscle relaxant to help them out. So some of the biggest pitfalls for making the diagnosis is that people are oftentimes a little hesitant with their having some of the less common symptoms. So anytime somebody has essentially any sort of skin complaint or angioedema, and there's any other symptoms that it's affected, whether they're having wheezing, they're tachycardic, or they're having GI symptoms, then it should be part of the differential. And if you can't think of any other causes, go ahead and giving the epi, like I said, is more beneficial, giving it early. Sometimes you can have it, people kind of mistake it for a COPD exacerbation for those that are wheezing or shortness of breath and tachycardic, but it should always be considered. And looking for the rash, at least on the trunk, is the most common place for the people to have a rash, the urticarial rash. So making sure you're kind of looking there, it takes just a second just to take a look under the shirt to see if there's anything there. And also, one of the other things is people tend not to ask too many questions when it comes to some of these patients, because they have wheezing, tachycardic, or if they have a history of asthma or COPD, go straight to just treating it that way. But also always asking, are they having nausea, vomiting? Had they been having any other symptoms or any known allergies? Just having a few more questions to ask is important, just to make sure that we're not missing something. Like I said, within the first hour is the most critical for the vast majority of these patients, as the highest mortality rates within the first hour, and up to 25% of patients that have an allergic reaction within the first hour, they can have a 25% mortality rate if it goes undiagnosed. So I kind of want to include just angioedema overall, because not all angioedema is anaphylactic. So I kind of some of the other things to help kind of tease out whether it's going to be anaphylaxis or not. Your two main other kinds of angioedema are ACE inhibitors and then hereditary angioedema. So just asking a brief kind of history as to what medications they're on. If they're on any of the ACEs, generally lisinopril is one of the most common ones. Enalapril was one of the primary culprits, but it's not used quite as often anymore. You have a higher incidence with enalapril than you do lisinopril. And then hereditary angioedema, and these are people that lack a certain enzyme, C1 esterase, and they can have, usually there's some sort of other family member that has a history of it in your younger patients, or oftentimes your older patients, they've already had a known diagnosis of this, and they'll generally be able to tell you that this is what's going on. But trauma is often an inciter for these people with hereditary angioedema. And it doesn't have to be trauma to the face. It can be any sort of trauma that would cause them to have any sort of immune reaction. Because anytime there's any kind of trauma, the immune system kicks in, and that can cause a trigger for angioedema in these patients. But in about 75% of them, there's no known inciting event for these people with hereditary angioedema. The biggest thing is trying to ensure that there's no airway compromise for these people. It can happen very quickly for them to have airway compromise. Oftentimes, we're able to just observe these patients in the ER, and it usually goes down on its own. But within just a couple of minutes, it can go from just being their lips being edematous to now we have a loss of an airway, and they'll have a laryngeal edema to the point that we're not able to pass anything through within just a matter of minutes. They can just be talking to you, and you can think that their swelling's going down, and all of a sudden they have laryngeal edema and airway compromise at that point. So kind of be on the alert with any of these patients, as it can turn very quickly. And the big thing is just to rule out that it's not an anaphylactic reaction, asking if they're having any other symptoms associated with it. For these patients, unfortunately, there's really not much treatment to give them, especially in the field. It's all going to be supportive, just starting fluids, just monitoring them, and just being ready in case there has to be any sort of early intervention for their airway. For these patients, your typical treatment, as you would do for anaphylaxis, your epi, Benadryl, steroids, none of that's going to be effective for these patients. For your ACE inhibitor-induced angioedema, it's just waiting it out. There's really nothing that we can do other than wait until the medication leaves the system. Sometimes they'll apply ice to the affected areas and try and get some of the swelling to go down, but it's just waiting and watching for these patients. And then the hereditary angioedema patients, there is some medications that you can give, but it's going to be in hospital only. It's not something that y'all would carry. So unfortunately, it's just kind of one of those butthole puckering things. Just watch them, and hopefully they don't crump on you. Just get them to the ER as soon as possible. So kind of in summary with that is having kind of a low threshold for anaphylaxis, because it is one of the most underdiagnosed things we actually come across in the ER for patients. And if there is any suspicion, go ahead and giving epi early on, because even if you're giving it early and they are having some symptoms, even giving IM epi, the half-life of that is still pretty short. So it's something that we can always just observe until it wears off, if it's not. But it's not something, like I said, it's not something that if you give it too late, it can still help. But sometimes it can be to the point that it's a little too difficult to try and manage them, and even starting them on an epi drip can be a little late for them sometimes. So giving it early if there's any sort of suspicion is the biggest thing. And anytime someone is hypotensive and have any sort of known allergen or a previous history of allergic reaction, even if they don't know if they've been exposed as the inciting event now, it should always be a consideration as a differential. And then your ACE inhibitor and hereditary angioedema. The biggest thing is just try and get them to the ER as soon as possible, and keeping an eye on them. Make sure there's no sort of airway compromise, because it's mainly just going to be a supportive treatment during transport for them. I mean, you can try and giving epi just in case there is a possible anaphylactic exposure or component to it, but overall, it's usually pretty ineffective for these patients. And so, are there any questions?
I'm not seeing any currently.
Only a few seconds behind, I think, this time.
What's that?
Only a few seconds behind. Just a few minutes. Maybe a minute. About a minute behind, actually.
Is there anything that you think you need any more information on or haven't covered for y'all?
I don't think so. You think of anything, Dustin?
No, sir. I
think it was very thorough. Covered the bases.
What did one of my guys ask about multiple bee stings? Let's see what he means here.
Is it more so if you're allergic to bee stings? Is it more severe if you're stung multiple times?
So it can be, yeah, because essentially the more exposure you have to whatever the allergen is, and with that being the bee venom, they can have a more severe reaction, and you're going to have loss of airway or development of essentially cardiopulmonary shock is more likely for those types of patients. And the biggest thing for them would be just giving them the epi IM, and then if you can get an IV, giving them the IV bolus as well on top of that. Just make sure that you're giving it over 5 minutes for the IV bolus. And then trying to, essentially, if you can, kind of raking off or getting, trying to brush off as many of the stingers that are there, because they can still continue to inject venom as long as they're in the skin. So trying to knock those off, giving the IM epi, and then if you can get an IV, doing the IV epi, but just be prepared for a possible airway compromise on those patients.
And the IV bolus was 0.1 mixed with 10 cc in a flush. Is that correct?
Yeah. So then it dilutes it down to a 1 to 10,000 ratio that way for giving IV. And then you can do the epi drip, and it gets to be calculated as to it's 0.01 mgs per kg in a 500 cc bag, and that's given over like an hour.
Oh wow.
Yeah, so if you have to do a drip, but just more often being able to give them the IM and then doing the IV is usually enough to at least kind of abate the majority of the symptoms. But the big thing is just being prepared for a possible airway compromise on those patients that have multiple stings, that have a known history.
Okay. They're kind of asking some questions about swelling and difficult intubations, and I know you kind of went over that.
Mm-hmm.
Obviously, the goal is to get ahead of it before you get to that point, recognize it, early recognition. But once you round that corner, depending on your level of licensure, it's whatever you can do for airway support.
Right. And I mean that's one of the things is that especially with the more the ACE inhibitor and hereditary angioedema, um, in the ER, you know, we have all the gadgets and gizmos we could possibly need for that, but I think one of the big things that gets underutilized frequently, especially if you have somebody that has a little bit of swelling, is the bougie. Because you got to think how small the bougie is, and just being able to get that there. And at that point, it doesn't, you know, we're not concerned about the tube size. You know, if you have to go down even to like a 6.0, at least you have something at that point.
6.0 is better than a 14
Yeah.
gauge needle. Sure.
Right. So I mean, you know, any sort of tube that you can squeeze down there is better than nothing, and we can always wait and switch it out or do something later. But that's one of the biggest things that I think it's underutilized for those patients that starting to have that laryngeal edema. If they have an allergic reaction and they start to become hoarse during transport, at that point, I don't think I would hesitate. You know, because if they become hoarse or they have any sort of hint of stridor, and you've already given them epi, I don't think I would really hesitate about intubating them, because at that point, that's your biggest sign for airway compromise, is that they're still having laryngeal edema after you've given them the epi. So that would be go ahead and get ready to intubate, because we can always extubate later if they improve. You know. So it's much better to get ahead of it if there's any sort of change in their breathing pattern, they become hoarse, or they develop any stridor after you've given that initial dose of epi. Just be prepared to go ahead and intubate early at that point, because otherwise it gets to the point that within a matter of minutes you could lose it and not be able to pass anything.
Okay. One of the guys said he was taught to use a credit card to remove the stingers, kind of in a scraping motion, versus tweezers. Is there any benefit?
No, I mean honestly, it's whatever is effective. I mean, I've even had people using towels. Just take a towel and just wrap, you know, kind of roll it up and just scrape it down the affected area. Because more often those stingers can get caught up in the parts of the towel. You know, it's rough enough that you can be able to catch it and pull it out. But it doesn't really matter what it is. The biggest thing is just trying to get rid of them to reduce the exposure. Yeah, I mean, if they have somebody that has, you know, ran into a hive and they have hundreds of stings, yeah, at that point I wouldn't be overly concerned about the stings. You know, I would start treating them, and while you're en route, if they stabilize, try and remove what you can. But the biggest thing is just going to be early administration, and then if they stabilize, then I would start worrying about removing the stingers. But you know, if you have somebody that still has refractory hypotension or remaining tachycardic after a couple of doses of epi, then I would just start moving towards the idea that they're probably going to have a point where they're going to start crashing if they're refractory at that point, and you can try and giving the IV bolus, but get to the point that probably going to have to intubate this patient, and then at that point I would try and remove the stingers if you can.
All right, that's what I see. Do you see anything else, sir?
No, sir.
All right, folks, I'm going to sign out of the live stream and make a couple of changes at once again. And we'll be live again in about, say, 10 minutes. And we'll go for another 30 or so. And then we'll have another change. So sign out for now and then check back with us in a few minutes. Thanks. Bye.